It is a pleasure to have here Dr. Jason Andrade from Vancouver. He is currently Associate Professor of Medicine at the University of British Columbia and Assistant Professor at the University of Montreal. He directs the EP lab at Vancouver General Hospital and has been involved in several leading tasks in the Canadian Cardiovascular Society, writing guidelines, and he has been a very powerful presence in the AFib field over the past few years. He is one of those individuals that you can read a lot of his papers, and every time you read one of his papers, there is an important message, an important question that's being addressed, and an important contribution made. In this era of industry-sponsored research, he's been able to combine successful clinical management, clinical trial conduct with getting the funding and all that stuff, with making meaningful contributions to the field that go beyond the interest of industry. So we're very fortunate to have Jason, and looking forward to your talk.
All right, well, thank you very much for having me. It's an honor to be here with you. So today I thought the focus will be on the importance of early ablation, but I'm going to kind of walk us through a little bit of background before we get to some of the nitty-gritty details around that. Here are my disclosures. And so usually when I'm giving a talk around atrial fibrillation, it's good to contextualize it in terms of the overall risk. And so historically, and I say historically kind of over the past 10 to 15 years, it was thought that atrial fibrillation was going to affect about 1 in every 4 people who are age 40, right? So it's a very common problem. It doesn't matter what you do across the realm of medicine, it's something you're going to encounter in your practice. But as I was working on something else, that estimate has actually changed. So on the plane down here, the more recent estimate is it's actually now 1 in 3 patients are going to have atrial fibrillation over their lifetime, right? So the prevalence is rising. It's something that we're seeing more and more commonly. It's affecting a lot of hospitalizations. The data I read yesterday was it's about $10 billion a year spent in the US on atrial fibrillation care. And part of that's due to the fact that atrial fibrillation is associated with a doubling in the mortality, 5 times higher stroke risk, and those strokes tend to be larger and more disabling, and a 5 times higher risk of heart failure. And so these are all the complications that come about once someone manifests their atrial fibrillation, and really are the goals of what we're trying to prevent in the long term. I already alluded to this a moment ago, but if you look at older data out of Europe, atrial fibrillation is about 2.5% of all healthcare expenditures. So if you look at public health systems, every dollar spent, 2.5 cents is really going to atrial fibrillation. So that's across all conditions, all problems, absolutely everything you can think of in medicine. That much of it is related just to atrial fibrillation care. So it's an incredibly expensive problem. And that's dominated by the acute care costs. So hospitalization, emergency room visits are a huge amount of expenditures around atrial fibrillation. So if I look at it from sort of a Canadian Cardiovascular Society perspective or provincial perspective, any intervention that we have that will reduce the need for someone to be hospitalized for atrial fibrillation has a potentially huge impact in terms of the costs of care and our ability to treat these patients. So really when we focus on our goals, stroke prevention, cardiovascular risk reduction, those are foundational. Those are the things that are going to improve the longevity of our patients and reduce the mortality. From a patient perspective, really the focus is on symptoms and quality of life and preventing complications. And so I'm not really going to get into stroke prevention and risk factor modification. They're foundational. They need to be done for all patients irrespective. Really the conversation for today is that focus around how do we manage the arrhythmia. And so historically, historically, going back to the 90s, the thought was that basically rate control, rhythm control were equivalent. And that's because there were several randomized studies that were done, including AFFIRM, STAFF, AFCHF. These are studies that basically took patients with established atrial fibrillation, randomized them to medical rate control or medical rhythm control, and observed that there was no difference in mortality, no difference in sudden death, no difference in cardiovascular death. And so that lack of difference sort of dominated the practice, and rate control became the default strategy for all of our patients with atrial fibrillation. The problem was it doesn't really tell the whole story. So if we look at quality of life, we know that quality of life is improved when patients are in a normal rhythm. So this is from the Realize AF registry. You see in the dark bars, essentially that's untreated atrial fibrillation. The middle bars are quality of life when you've rate controlled the atrial fibrillation. So there is a significant improvement. Patients do get better. But the biggest improvement was in those patients who were in sinus rhythm. And if we go back to all of those randomized studies like AFFIRM and AFCHF, very consistently, if you were in a normal rhythm, your quality of life was much better than if you were not, right? So then that messaging was lost a little bit in the original trials, is that if we're taking a patient-centric approach, the improvement in their quality of life and symptoms is going to be much better with rhythm control that's effective. Likewise, if you look at the mortality question, the studies that were done suggested there was no benefit in those studies in terms of reducing all-cause or cardiovascular death. But there were other studies that came along, like Diamond or CHF-STAT. These were antiarrhythmic drug trials. They were observing a reduced mortality in these antiarrhythmic drug trials, even though they were not performed for that purpose. The graph I'm showing you is observational data out of Quebec, Canada. And what they did is they looked at claims, patients with rate control or rhythm control, and followed them out on what you can see is a very long time horizon. And so early on, in the first year or two, there was an association with less mortality if you were rate controlled. That became parity around 2 years. And then you see that mortality steadily fell over time. And so if you just track the average follow-up in the landmark trials that were done, you see that there would be no expectation that the mortality would be better with rhythm control. They were too short of a follow-up. And so a couple of years ago, EAST-AFNet was done. EAST-AFNet took newly diagnosed atrial fibrillation, randomized them to antiarrhythmic drug therapy or rate control, essentially. And they saw about a 30% reduction in death, a 30% reduction in stroke. And one of the reasons they likely saw a positive result is just that they followed patients long enough to actually realize those benefits. So if we think about our practices, how old are the average AF patient that we see? When we see someone in their 60s, they have 20 years of life ahead of them. So making decisions based on trials that follow people for 2 years is probably underestimating the effect. And we have to think about that long time horizon. Likewise, if you look at the outcome of stroke, again, antiarrhythmic drug trial in Athena observed a lower risk of stroke compared to placebo. Quebec cohort is this graph that I'm showing you again, a similar result. So the stroke reduction, those types of things are going to be longer term data. And so this is kind of just to set the stage as to why would we pursue rhythm control in these patients. And I think that there is significant benefits both to the healthcare system as well as to the patients themselves. The question really is then how are we going to do it? And up until a couple of years ago, the expectation had always been that we would trial antiarrhythmic drugs, see if that could hold someone in a normal rhythm. When that failed, we might trial a second drug. When that failed, we might then go on to a catheter ablation. And so that approach probably was based on the perception that drugs were good enough and there was lower risk with drugs. Ablations are invasive procedures, potentially not that effective, depending on your perception, and potentially higher risk procedures. But I don't think the evidence necessarily supports those assumptions anymore. So for antiarrhythmic drugs, we have many randomized placebo-controlled trials that show that antiarrhythmic drugs are relatively more effective than a placebo at preventing atrial fibrillation recurrence. The relative effectiveness differs by agent, amiodarone being probably the most effective, dronedarone being potentially the least effective, but relatively speaking, you see significant reductions in atrial fibrillation recurrence with antiarrhythmic drug therapy. The problem is in absolute terms, they're not that effective. So in early AF, where we had loop recorders, patients randomized to standardized, aggressively titrated antiarrhythmic drugs, giving them 3 months to optimize their medications, and then following them out for the rest of the year. Despite these standardized protocols, less than a third of patients were able to be free of arrhythmia at a year. And so while it's better than nothing, in absolute terms, you're still going to dominate with recurrences. In contrast, we have many randomized controlled trials that have been done that have compared antiarrhythmic drug therapy to ablation, and in each of these trials, it's been effective. These are the second-line trials, so these are trials where patients are randomized after they failed a drug. Arguably, these are biased from the get-go, because if you failed a drug and then you get randomized back to a drug, you should probably fail it again. And so all of these trials that had been performed while showing that ablation is better than drugs, there was still some uncertainty. And so a couple of years ago, there was a few trials that reported, one of which was our early AF trial. The US, there was Stop AF First, and there was a third one out of Europe and South America called Cryo First. These trials took patients who were treatment naive, meaning that bias was no longer present. So they could have theoretically responded equally well to both drugs and ablation because we hadn't selected out the people who were doomed to fail. And even then, we saw a 50% reduction with ablation. So it seems like as a first therapy, we're much more likely to prevent recurrences of asymptomatic atrial fibrillation, symptomatic atrial fibrillation, and reduce the burden or the time spent in atrial fibrillation when we pursue catheter ablation as a first treatment, rather than doing antiarrhythmic drug trials. Patients may or may not care about recurrences of atrial fibrillation. I think from their perspective, really it's that question of symptoms and quality of life, those patient-reported outcomes. If we walk our way back to those rate versus rhythm control trials, so PF was one of those trials. Here I'm showing you the baseline, I think it's SF36 domains, the rate and rhythm control in dark and light gray. The important thing here is you can see that when patients with untreated atrial fibrillation on the top graphs are treated on the bottom graphs, those blue arrows are highlighting significant improvements from baseline. So again, patients with untreated atrial fibrillation will do better when you treat their atrial fibrillation. But the key thing here is that there's absolutely no difference between pharmacological rhythm control or pharmacological rate control. So drugs didn't seem to have a benefit. Just a month ago, there was the sham PVI trial that was performed. So this was a sham trial. So patients were randomized to either having a catheter ablation procedure or coming to the lab and having all of the motions done, including groin access and phrenic pacing. They were blinded to whether or not they actually had an ablation during the procedure, and then they left. The placebo or the sham group were cardioverted, so they were put back into a normal rhythm. And despite cardioversion and active management, you can see that every quality of life metric was better with a catheter ablation procedure. So the idea that catheter ablation is just a placebo effect, I think, doesn't hold anymore. We know that in this sham environment, catheter ablation is going to improve quality of life much better than just active rhythm control with no ablation. And if we go back to our randomized trials of first-line therapy, we can see that that was also observed in those studies. So if you were randomized to ablation, the difference in your effect score, so effect score is a disease-specific quality of life metric. It's very sensitive to change for patients with atrial fibrillation. A change of 5 points is considered clinically meaningful. So arguably, if you saw the patient in your office, you would perceive them to be better, is a change of about 5 points. And you can see that the difference between having a drug-initiated versus having an ablation procedure exceeded that difference at 6 months and 12 months across all of these trials. And importantly, even out to 3 years of follow-up. So this is a single time point intervention of a catheter ablation procedure. Even 3 years later, patients were significantly better in terms of their quality of life on the disease-specific score, on the generic score, which is the EQ5 dimension, or Euro Quality of Life 5 dimension, and their symptom scores. So one time point gave you a very durable, consistent benefit over many years of follow-up. And so again, suggesting that there's benefit to the patients long-term from an intervention. We work in a publicly funded single-payer healthcare environment, so all of our procedures, all of our healthcare is provided by the government. So when I have to then go to the government and argue, we should have more atrial fibrillation ablation procedures, we have to show value for that. And one of the ways that we see that value, and I kind of mentioned this at the beginning, is looking at the downstream effects of our interventions. So healthcare utilization in terms of cardioversions, emergency room visits, and hospitalizations. Excuse me. And so this is data out of another study that we did called Circadose. In that study, all 350 patients underwent a catheter ablation. It was just pulmonary vein isolation. What we did for this analysis was compare the 12 months leading up to that intervention to the 12 months that followed that intervention. And what you can see across every single way that we've measured it is there's a significant reduction in healthcare utilization. So whether it's the proportion of patients who have an intervention, the number of interventions they have, the total number of interventions overall, it didn't really matter how you measured it. Healthcare utilization in the year following intervention substantially decreased. Now, a criticism of this type of analysis is that patients might have regression to the mean. So when you have your ablation, you're likely at peak healthcare utilization. You should accept or expect a significant decrease that follows. But again, if we go back to those first-line trials where we remove that bias, what we're seeing is a significant decrease or significantly lower healthcare utilization in the year that followed with that randomization. And so patients had a significant 60% reduction in hospitalization and an overall healthcare utilization rate that was 30% lower than if you were randomized to drugs. So again, if I take the perspective of the healthcare environment and I have a patient presenting to me, I can give them a therapy that doesn't have an upfront cost in medications, but I'm going to pay for that in the fact that they're going to come to the emergency rooms, they're going to get cardioverted, they're going to be hospitalized. Whereas the upfront cost of ablation, you'd expect that these significant decreases in rates would be associated with significant savings. So I don't think from an efficacy perspective, there's necessarily any doubt that ablations can be more effective at preventing recurrences. And the downstream effect of those recurrences being prevented is the fact that we're going to see better quality of life and less healthcare utilization that follows. So the second part of that sort of conversation has to do with the potential adverse effects or the significant side effects that come along from ablation. So it's an intervention, it's invasive, it has risk. Drugs have side effects, but theoretically not much risk. But if we go back to these earlier data, so the network meta-analysis that was performed against placebo, we see that the tolerance of antiarrhythmic drugs is less than placebo. Now, I don't think this is going to be, again, surprising to anyone. If you have active drug versus nothing, you're going to expect more side effects. In a significant proportion of patients, those side effects will require the medications to be discontinued. So that would traditionally be your reason to go ahead for a catheter ablation procedure. One of the things that I don't think was as well appreciated is that some of those intolerances are actually to do with the increased risk of mortality with these medications. So if we look at the AFFIRM study, AFFIRM again randomized patients to rate control versus rhythm control with medications. And we knew that we knew that quality of life was much better if you were in sinus rhythm. But actually, if you look within AFFIRM, you can see that mortality was reduced by 50% if you were able to maintain sinus rhythm. The counterpoint there, though, is if you needed an antiarrhythmic drug, your mortality was increased 50%. And so one of the arguments as to why AFFIRM was a negative trial is just that the therapy we were providing was so toxic that we were unable to realize the benefit. And so when we looked at some of the patients within our own early AF study, again, this study had loop recorders implanted in every patient, standardized antiarrhythmic drug titration protocols. Some of the adverse events that we saw were this. So in a sotalol-treated patient, a polymorphic wide complex dysrhythmia. In a flecainide-treated patient, a monomorphic wide complex dysrhythmia. So even with standardized, very intense monitoring associated with the use of these medications, we still saw that there was significant harm associated with them. Now, if we go back to early AF, I guess the question that comes out is, how does that compare to a catheter ablation procedure? So within early AF, we had the 1-year follow-up, and you can see that patients randomized to a catheter ablation procedure or antiarrhythmic drugs had a statistically similar risk of any adverse event or serious adverse event. Now, any safety endpoint was a more broader definition. The serious adverse events was stuff that we felt was significantly important. And so this was things like pacemaker implantation, syncope, heart failure, acute coronary syndrome, death, those types of things. And so at 1 year, though the point estimates are lower with ablation, again, we didn't see any difference at a year. But as we follow these patients out to 3 years, what we saw is that that benefit started to emerge. And so now serious adverse events, again, had a very similar point estimate, or a much lower point estimate, but it was still non-significant. If we look at any safety endpoint, now it's significantly different out to 3 years. And so conceptually, the question is, why is this? And I think that the easiest way to think of it is to think of it like a mortgage. And so if you look at a mortgage, you can take the cost up front. So you can just pay for your house. It'll cost you $300,000. It's done. That's what a catheter ablation procedure is. It's a front-loaded risk. But then there's no risk that's going to follow you for the next few years. Antiarrhythmic drugs are like a mortgage payment. So it's a small amount that you take every day. So that risk is small every day you take that drug, but that is a risk you take every day you take that drug. And as time goes by, there will be a point where the risk of those drugs in a cumulative level exceeds the risk that you took when you had your catheter ablation procedure. And I think that that's basically what we saw with an early AF. At a year, there was a suggestion that the risk with an ablation was lower than with a drug, but it was not significant. But as we followed those patients out for the 3 years, and patients continued to take those medications over 3 years, that risk now became quite high. The other point is that we need to realize that the current ablation procedures that we do are relatively safe, and they're getting safer as time goes by. And so this is an analysis that we published in JACC about a year ago. And what we did was we looked back at 10 years of catheter ablation randomized control trials. So, reasonable endpoint adjudication. This isn't observational data. This is what was published in the literature. And we divided it based on an early period and a late period. So the early period is 2013 to 2017, so it's still fairly contemporary procedures. The later period is 2018 to 2022. And what you can see is that as our procedures have matured, as a community, despite taking on more persistent AFib instead of paroxysmal AFib, taking on more heart failure patients as opposed to less heart failure patients, our risks have gone down, right? So the major complication rate has dropped from 3% to under 2%, so 1.87 or something like that. If you look at that by what is the component of that risk, the vast majority of the risk is merely getting into the left atrium. So 1.1% of the risk is a groin complication, 0.6% is basically your transeptal or tamponade. Everything beyond that is very, very small. The risk of stroke is 0.1%, the risk of pulmonary vein stenosis very low. So most of what we're doing from a community is our procedures are getting better, they're getting safer, they're getting quicker, and the risk of the drugs hasn't really changed. And so now, by bringing down that risk of intervention, we're seeing that we can realize the benefit of our intervention without necessarily conferring significant harms. And these studies, you know, as we say, it's up to 2022. This isn't really considering other changes that we're seeing in our community, such as pulse field ablation, which theoretically is going to have a safer profile relative to the older radiofrequency or cryo balloon ablation procedures. And so relatively speaking, I think if we look at the safety outcomes between considering drugs versus ablation, again, ablation seems to be favored in that regard because it confers an upfront risk that is now reasonably small, and then you get benefit over the long period of time. Now, the third piece to consider that doesn't usually come up in our conversation pieces is a lot of the trials that we do around atrial fibrillation tend to be focused on outcomes at a year in terms of ablation, 2 years if we're looking at other things like FIRM, but we don't tend to look at what happens to the disease over time. And so we know that atrial fibrillation is a chronic and progressive disorder, so it's not a static disease. You don't just have atrial fibrillation, it's going to be like this for the rest of time. It's something that will evolve. Patients will have a change in the pathophysiology that underlines it. So the early atrial fibrillation that was treated in something like the EAST-AF study is something that's happening in a relatively normal heart. It's an electrical problem. But over time, as those episodes accumulate, you see changes in the atrial myopathy. It becomes a structural problem. It becomes a more advanced form of atrial fibrillation. Clinically, we sort of we perceive this as a change in the pattern. We'll classify them as paroxysmal AFib or persistent AFib, and this is largely a reflection of how often they're having episodes. So atrial fibrillation may start as a single episode. There may not be another episode for a few years. Then they start to have little clusters of episodes, but they're all self-limited. Eventually, the clusters start to be longer episodes. They may get to the point where they're coming to the emergency department for cardioversion because it's not stopping on its own. And if you leave this long enough, eventually it becomes something called permanent atrial fibrillation, where basically we just give up and leave them in atrial fibrillation forever. There's been several studies done that have evaluated this. It's about 8%, 7% of patients that will progress every year. Interestingly, if you take device-detected atrial fibrillation or these little atrial episodes seen on a pacemaker, about 8% of those per year will become clinical atrial fibrillation. Once you've got clinical atrial fibrillation, which is usually paroxysmal as its first presentation, about 7% or 8% of those will go on to persistent atrial fibrillation every year. That usually is driven by things like their cardiovascular comorbidities. We tend to see it in people who are older, people who have hypertension, who have valvular pathology, a lot of those other comorbid conditions that we would actively try and treat to prevent this disease from getting worse. The reason why this matters, though, is that within atrial fibrillation, the risk is not homogeneous. So patients who have paroxysmal atrial fibrillation have a lower risk of death compared to patients with persistent atrial fibrillation, about 22% higher risk of death if you have more advanced forms of atrial fibrillation. Your risk of having a stroke is about 40% higher if you have persistent atrial fibrillation, and your risk of developing heart failure is about doubled if you have persistent atrial fibrillation. Now, it's interesting that even though these are comparable or comparative risks between two disease states, that transition period also appears to be a very high risk period. And so this is data out of the Fushimi registry in Japan. There was actually a paper just published a couple of months ago that shows almost the exact same data out of another Japanese registry. But what they've shown is that, again, the risk is higher as you go to more advanced forms of atrial fibrillation in terms of stroke or heart failure hospitalization. It's basically doubled as you move into the more advanced form. But that transition period, in that year around where people progress, is a very high risk period. And so you have an almost 4 times increased risk in terms of stroke, 3 times increased risk in terms of heart failure as patients move categories, as they move from paroxysmal to persistent AFib. Once they've then gotten themselves into persistent AFib, they reset at a lower level, but again, that level is still higher than it had been had they been in paroxysmal AFib. And so this idea, I think, highlights another potential target for intervention for us as a community, is that if we recognize this as a chronic progressive disease, is there anything that we can do as a community to prevent that progression? And so one of the things may be to aggressively work on cardiovascular risk factors, be much more intensive around comorbidity management to help prevent that risk of recurrence. The question is whether or not intervening on the rhythm may have an effect as well. And so my mentor over in Montreal, Stan Natel, previously published a paper where he argued that a logical approach to preventing progression may be just to be very aggressive at maintaining sinus rhythm early in the disease state. And if we can aggressively keep someone in a normal rhythm, that'll prevent that atrial fibrillation-induced remodeling, which then drives that progression to atrial myopathy and more advanced forms of atrial fibrillation. And earlier on, I alluded to the pathophysiology being something very simple like this. So you have a pulmonary vein that fires, that pulmonary vein triggers reentry, and that causes you to have more persistent forms of atrial fibrillation. The problem is this is a gross oversimplification. The pathophysiology of atrial fibrillation is more complex and largely looks like this. You have intracellular calcium handling abnormalities that drive atrial fibrillation episodes as well as progression. That leads to ion channel dysfunction. You have structural remodeling. You have the autonomic nervous system, which also impacts the episodes as well as remodeling. It's a very complex system that doesn't entirely get managed just as a simple kind of target trigger versus substrate approach. In terms of options, medications are largely work on the calcium channels or the ion channels, so that's most of where they're going to have their effect on the pathophysiology of atrial fibrillation. But you can see that a lot of that pathophysiology is largely untouched. And so there's been studies that have looked at high-burden paroxysmal atrial fibrillation. This is out of Australia, John Kalman's lab. And you can see in the red line is essentially patients who don't have atrial fibrillation in those 2 graphs. The blue lines represent patients with high-burden atrial fibrillation, and they either had catheter ablation or they had an antiarrhythmic drug. So catheter ablation is the light blue line, antiarrhythmic drugs is the dark blue line. And then they're followed out to a year, okay? The top graph is showing you a marker of structural remodeling, so left atrial transport function and echo. The bottom is showing you electrical remodeling, which is, in this case, P-wave duration. So what I want you to see on these graphs is that the red line is someone who does not have atrial fibrillation. At the very beginning, the 2 blue lines are very far apart, meaning that they have abnormal electrical function and abnormal structural function. If you had a catheter ablation, that light blue line comes right back up towards that red line. So essentially what's showing is that you're getting beneficial remodeling. Your electrical and structural remodeling can be undone by an invasive intervention. But if you're on a medication, those blue lines either stay far apart or get even further apart from patients who don't have atrial fibrillation. So the adverse remodeling continues to get worse with a drug, whereas an ablation seems to improve you back to a more normal baseline. And possibly that's due to the fact that atrial fibrillation ablation does affect a lot of these areas. So just doing a pulmonary vein isolation will isolate those triggers. The antral region, or the area just outside the pulmonary veins, is a driver for substrate or reentry, so that AF persistence. Just sitting outside the pulmonary veins are what we call ganglionated plexi, so autonomic nervous control of the heart. So when we do a pulmonary vein isolation, we change the autonomic milieu, which may prevent some of those recurrences as well as the progression. And again, that has been shown to result in structural remodeling and shrinking of the atrium. And so what we had done in a previous study is we took these patients with untreated atrial fibrillation, again, randomizing them to a catheter ablation or antiarrhythmic drugs with this standardized drug titration protocol, following them out for 3 years with a loop recorder. And what we saw is in this relatively healthy population, about a 75% lower rate of progression to persistent AFib as detected on a loop recorder when you had a first catheter ablation versus drugs. Now, the rates of progression you can see are much lower than what I had told you previously, and I think that that's a reflection of the fact that the population was relatively healthy. The counterpoint there is, though, even though your population was relatively healthy, there still was significant rates of progression with antiarrhythmic drug therapy. And so the disease will continue to evolve and will continue to fester, even in a population who has very few comorbidities. And that interventions that we have early on can change that treatment course, can change that trajectory of disease. Interestingly, there's other data. So in our Circadose study, we saw that prior to ablation, about 9% of patients progressed, again, what we would have expected based on the event rates. But 81% of those patients who progressed to persistent AFib regressed and did not have another episode of persistent AFib over the 3 years that follow. The bar graph is showing you a study out of Australia called CAPLA. CAPLA was an ablation trial randomizing patients to 2 different strategies, but they all had persistent AFib. And those patients that had the ablation, you saw that about 55% of patients had no recurrence, but the majority of patients who did recurred with paroxysmal AFib. So the idea that if we are a little bit delayed in getting to their ablation, we can still bring them back. If we're very delayed in getting to their ablation, we can still bring them back. So ablation not only prevents you from progressing, but if you've already progressed, seems to be associated with regression or bringing you back to an earlier form of atrial fibrillation. And I would argue that drugs mostly are focused on symptom control and just kind of taking care of the episodes, but they're not doing anything to affect what's happening underneath in terms of the atrial myopathy process or the underlying progression of atrial fibrillation. And catheter ablation does seem to have a role with a very fairly consistent response, no matter when you put it in its disease trajectory, in terms of turning back the clock and preventing progression. So if we know that rhythm control is associated with significant benefit, we know that ablation is better than drugs and probably in the long term safer than long-term antiarrhythmic drugs, and that it may offer us a benefit in terms of altering the disease trajectory. The question is then, how quick do we need to be providing ablation? And I would say that even if you have persistent AFib, ablation can turn back the clock, but the procedures that we have for paroxysmal atrial fibrillation work a whole lot better. And so when you have a normal atrium with abnormal pulmonary vein signaling driving the atrial fibrillation, doing a pulmonary vein isolation is going to work very well. We know that isolated PVI is a very effective therapy for paroxysmal AFib. When we apply that same therapy to persistent AFib, the success is less good in terms of recurrences. So this is just comparing 2 different studies using the exact same technology. So the procedure that patients received did not differ. The only difference was who they were in terms of paroxysmal versus persistent. And you can see that recurrences are going to be higher with persistent. And so as an EP community, we think we need to do more for these persistent patients beyond the pulmonary veins. The problem is a lot of the interventions that we have either been ineffective, like fractionated ablation or linear ablation or scar-based ablation, and there hasn't been consistent response to show us benefit. I think the vein of Marshall is probably the one that has shown the greatest benefit, but we're still fairly limited in terms of the therapies we offer. In addition, if we wait until the atrial fibrillation is in a more advanced form, like persistent atrial fibrillation, data out of Ontario would suggest that the post-procedure outcomes are going to be worse. And so if we look at the rates of hospitalization after an ablation for persistent AFib, it's much higher in red compared to if you did a paroxysmal AF ablation. If you look at the all-cause mortality, it's worse if you're having an ablation for persistent AFib relative to paroxysmal AFib. And so delaying it until someone is persistent is not going to be a benefit to them. And so the idea that once we've made the decision, we need to get on it a little bit earlier. Now, the counterpoint is that there may be a sweet spot even within what we classify as paroxysmal AFib. So paroxysmal AFib within the guidelines is defined as atrial fibrillation episodes less than 7 days. Beyond 7 days of continuous atrial fibrillation, we call it persistent AFib. But the outcomes to ablation don't seem consistent within that category. And so this is data, again, out of Circadose. So all these patients did have a catheter ablation. They had loop recorders in place. We monitored them for several months prior to ablation, did their ablation procedure, and then followed them. And so what we did was classify patients based on their AF episode duration on a loop recorder prior to ablation, and then just looked at their post-ablation outcomes. They all had the same procedure in terms of PVI. And you can see that the curve that stands out there is the patients whose episodes are limited to less than 24 continuous hours. So if your atrial fibrillation is 8 hours, 10 hours, 12 hours, 16 hours, whatever, if your outcome, or if you had a catheter ablation procedure, your success was much better. But once you started to have episodes that were lasting longer than 24 hours, so 36 hours, 48 hours, 5 days, whatever, your outcomes were actually no different than if you had persistent AFib. And so it seems like even within paroxysmal atrial fibrillation, which again is associated with lower rates of hospitalization, lower rates of death post-procedure, better outcomes, even within that category, there's a group that will have an even better outcome compared to the rest. So if we have the ability to monitor patients more closely, as long as their episodes are happening within 24 hours, I think we're going to be okay. Beyond 24 hours, it's telling us that they're probably heading towards that inferior outcome once they have their intervention. We need to be a bit more aggressive with that group. Another way of looking at this is something called the diagnosis to ablation time. And so this is a metric where basically they've tried to define how long has it been from your first episode of atrial fibrillation to the time that you have your catheter ablation procedure. There's issues with this metric, which I won't really get into, but basically several studies have been performed. They've suggested that if your time to ablation is within a year, your outcome is going to be much better. Once you get past a year, then you start to see the success drop off. In this case, all-cause hospitalizations start to rise. And in the in the table there from Utah data, which is about 10 years old now, you see that the rates of stroke post-procedure increases, the rates of heart failure post-procedure increases. And so it's been argued that, you know, if someone's diagnosed with atrial fibrillation, they're highly symptomatic, we should be intervening earlier, and probably within the first year after that diagnosis will be associated with better outcomes relative to waiting longer. Now, in Canada, our wait lists for procedures are a little bit longer than most other places. And so we've actually looked at what happens while people wait. And so this is data, again, out of Ontario. I think it's about 6,000 patients that were waiting for their catheter ablation procedure in this data set. And so these are patients who have seen their cardiologist, they've been referred for their ablation, they've seen their electrophysiologist, they're now on the wait list, waiting to have their procedure. And it's about 277 days that they waited before they had their ablation, so 9 months or so. So what happened to those patients over those 9 months? 10% were hospitalized, 40% went to the emergency department, and about 9% progressed to persistent AFib just while sitting there waiting for their procedure. And so it's important, I think, from us in our health environment that we recognize that once the decision is made, there's no benefit in delaying, right? If we leave them for 9 months, they're still going to come to the hospital, they're still going to come to the emergency room because they haven't had their definitive therapy. They're going to have progression of their disease, which should regress after the ablation, but 1 in 5 it won't. And you're going to have other problems that come about. So patients don't just stop having issues with atrial fibrillation once you've made the decision to ablate them. It's only when you get them to the ablation that you can actually provide that therapy that will provide them with the intervention. And so I think where we sit in terms of the lessons learned is that we know that treating atrial fibrillation is going to improve clinical outcomes. It's going to make people feel better. It's going to prevent them from being users of our healthcare environment, which will then lead to significant cost savings to healthcare systems. We know that ablation is going to be much more effective than drugs when we provide it as a first therapy. We previously knew it was better than drugs as a second-line therapy. And if we are more comprehensive in our intervention, so in partnership with risk factor reduction, we can actually change the trajectory of disease and prevent patients from getting onto those more advanced forms of atrial fibrillation, which in theory should result in lower long-term complications like stroke and heart failure, which is ultimately, I think, what we want to prevent. So thank you very much for having me.
I need the microphone. Thank you, Jason. That was brilliant and very thorough and compelling. And even though you make a compelling case for early ablation, I want to play contrarian for a little bit here. Common perversion of that concept is we get consulted for a patient that's been healthy, runner, thin, athletic, and then goes out and celebrates some professional accomplishment, gets a little bit drunk, the next morning is in AFib. And then they come to us, 2 weeks later for ablation. So, there's a time in the course of the disease where you need to intervene on other things that would lead to better health of the patient, like whatever, alcohol abstinence is one, be active physically, treat sleep apnea if you have it, treat obesity, all these things. So how much AFib is sufficient AFib to warrant an AFib ablation versus implementing other health maintenance habits?
Okay, so I think there's different parts to that. So the first part is, reversible AFib, you treat the reversible cause, right? Like, first principles of all medicine is if there's something there that triggered this, fix that, and then see where it lands, right? And so, much like my perspective on like pacemaker detected arrhythmias is kind of like that. Same thing if you're in the ICU and you have atrial fibrillation. You have something that has kind of pushed you over the edge. Probably the why is there's something abnormal about the heart. You have comorbidities, you have other triggers, other substrate abnormalities that ideally removing that reversible trigger is going to fix. And so it's kind of like the canary in the coal mine. When you have device-detected atrial fibrillation, it's a sign to us that we need to get your blood pressure better controlled, you need to exercise, you need to lose weight, sleep out, like all of those things. But it doesn't necessarily mean I need to jump in and ablate you. It means that you're at risk for this being a long-term problem. If we look at data around first presentation of atrial fibrillation, up to 50%, depending on the series you read, will have no atrial fibrillation the next 3 years. And so why would I ablate someone who's not going to have another episode of atrial fibrillation for 3 years? I mean, I will look like a fantastic ablationist, but I haven't changed anything for that patient. And so, when we designed early AF, we specifically did not go after first presentation of atrial fibrillation. The median time, or the median duration of atrial fibrillation in the study was 1 year, up to 3 or 5 years on the higher round. And the reason that we did that is that we didn't want to capture people at first presentation because we knew that a lot of them wouldn't have another episode. And we don't really need to treat first presentations of atrial fibrillation. Probably what we need to treat is what I would say is the inflection point of their atrial fibrillation. And so early AF was designed to treat people who were becoming highly symptomatic. They were having intrusive atrial fibrillation that was frequent. So by the time they got into the study, they were having 3 episodes of atrial fibrillation a month. Their quality of life was impaired, but they hadn't had a treatment yet, right? Like the question we were asking is what should their first treatment be when their atrial fibrillation is clinically problematic? We don't necessarily need to go after the first episode.
I fully agree. Also, can you comment on specific techniques? Because we're happy to embrace and proclaim success that we're altering the course of the disease and the pathogenic processes that go into persistent AFib. But this only works in 60% or 70% of the time. So is there room for a better ablation? And specifically, I would like you to comment on differences in progression with radiofrequency versus cryo.
Yeah, so part of that answer is the conversation around what is an outcome after an ablation procedure. When we looked at Circa-dose, I remember presenting it, I think it was 2019, might have been 2018 actually. But I presented it at ERA and was resoundingly kind of beaten down, right? So we had loop recorders in everyone. Our success rate was 53%. Right? And so I get up on stage, I present to the EP community a success rate of 50%. We're all called incompetent, like, this is terrible. How can you offer a procedure like that? But it's just, what we're recording is not necessarily what mattered, right? And so if you actually compared like for like, our success rate was 80% in terms of symptomatic episodes of atrial fibrillation that were meaningful. We were actually, better than the trials that had been done with comparable technologies. It was just down to how we found it. And we found it because we're monitoring everything, and if 30 seconds of anything is detected on a loop recorder, that's a failure. And so, what does that mean? Well, as we kind of dug into that data, the burden or the amount of time that these patients were spending in atrial fibrillation went down by 99%. Right? The vast majority of recurrences that were there were nothing recurrences. We never would have found them had we used a Holter monitor or a 14-day monitor even. And so, when when we talk to patients and we set expectations, it's an 80% chance with paroxysmal atrial fibrillation that you're going to be better. And you might have a recurrence over time, but it won't be as bad as it was. If we look at persistent AFib studies, the outcomes are 40% success. But if you look at CAPLA, CAPLA tells you that the time spent in atrial fibrillation for these persistent atrial fibrillation patients is much, much less because most of the recurrences are paroxysmal, right? So we are changing the disease. We are changing what's happening. In terms of the technology piece, it's difficult because we don't have a lot of comparative trials. Within circa dose, when we looked at progression over 3 years with loop recorders, again, we saw a significant reduction with ablation. So if you look at the pre versus post, about an 80% difference in the rate of progression, so very similar to what we had seen in early AF. But within the post, we saw all of the progression in the cryoballoon group, no progression with radiofrequency. And so in early AF, the progression rate was 3%. I think it was very similar with circa dose, but just a little bit higher because it was, again, a population more advanced down the disease. But for some reason with radiofrequency, there was nothing. We don't know what the progression rate is going to be with pulse field ablation. We just don't have any studies. And so it may be that the technology, the way we injure the tissue, the way it affects the autonomic nervous system and the structures in and around the atrium has a role. All I can say now is consistently as a first-line therapy, as a second-line therapy, and even as a third-line therapy after a failed ablation, doing an ablation changes that progression rate.
Thank you very much, really, for an amazing presentation, and thank you for your contributions to the field. You've convinced me to act early. I have two questions for you. One, along the line of what Miguel asked, is when is this inflection point? I mean, if you're taking care of triggering factors, alcohol, whatever it is, what is the inflection point? And is it once a year, twice a year that these paroxysmal atrial fibrillation is occurring? So that's when is that inflection point? And do we have data regarding that? The other is there any role from what you're trying to tell us for pharmacotherapy? Once you have this, and has that changed the guidelines as to what is the guideline for people with paroxysmal AFib?
So the inflection point piece, I don't think it's universal, and this is where it becomes a little bit more difficult. So, last month at ESC, I had to debate John Kalman, who is, one of the authors of CAPLA, who's kind of a luminary within Australia. And my position was we should be doing ablation for a first-line therapy for persistent AFib, and he was the counterpoint. And so he, in his counterpoint, had this wonderful figure kind of illustrating this, is that you can have your first episode and you can immediately, have this inflection point, and you're just like, your first presentation is like, okay, well now you have AFib, and it's happening frequently, it's problematic, it's difficult. That person, you would go then. Someone else, might have alcohol-triggered atrial fibrillation, so they have a holiday heart, then, life settles, they're fine for a year or two. And then all of a sudden, now they start having their atrial fibrillation because the substrate was brewing underneath all of that. I mean, arguably, it's very similar to what I would say is, pacemaker-detected atrial fibrillation in the sense that it's little sputters of something that we only know about because we're monitoring these people all the time. We know that 8% per year will go on to develop clinical AFib, but that means 92% per year don't, right? And so the trigger is not the first time you see it on the pacemaker. It's, as that time goes by, who are we going to need to go and intervene upon? There's been studies done. CAREF was a Canadian registry that looked at this. They looked over 10 years, and 50% of patients may not progress, or 40% of patients may not progress. And so you don't necessarily want to intervene too soon. I think from my perspective, it's really down to that question to the patient, how are things? Are you doing well? And if you're not doing well, then what do I need to do to make you well? And patients will report that, the episodes are coming more frequently, they're more severe, they're going to the emergency department. All of that kind of gestalt is the time to say, let's do something for you. And then the question just comes down to what should we do? Do medications improve quality of life? They do, relative to nothing. Do they prevent recurrences? They do, just not as well, right? So it's not to say that all medications are completely out. I mean, EAST-AFNet, which showed the 30% reduction in stroke and cardiovascular death, that was almost exclusively medications. 80 to 90% of the patients in that trial did not have an ablation. So there is still a role for medications. I just think that we need to think about an ablation as the first therapy. We need to have that conversation early on, and I don't think that as a community, at least within Canada, that ever factored into a conversation. Patients still are on years of medication trials before they ever get to seeing an electrophysiologist. I mean, I saw someone 2 days ago who for 3 years had just been sitting doing nothing. 2 years ago went to persistent AFib from their paroxysmal AFib, and now they get referred to me with longstanding persistent AFib, having not been in sinus rhythm for 2 years. I mean, what am I going to do for that person now? I've lost a significant opportunity there by not seeing them 3 years earlier. And so, medications, yes, they have a role, but we can't forget that there's more benefit with the ablation, and we need to consider that at a time where we can maximize the benefit.
I guess your approach would be if medications don't work, act, right? Is that a correct statement?
I think a lot of it comes down to that balance around how long are the episodes happening. And so if we're within, the episodes are a few hours and they either are taking medicines as needed as pill in the pocket, or they're taking it regularly and they're doing fine, I'm not compelled to say I absolutely have to do something for you. But as soon as the medicines don't start to work, as soon as the episodes are getting near that 24-hour threshold, then I'm more worried that we're going to lose our benefit. And at the same time, as I say, like our wait list right now is 9 months to have an ablation from the point you see me. So beyond the point where that person sees their cardiologist, then gets referred to me, which is say 3 months, to when they have their ablation, which is 9 months later, already a year has passed. We're not doing nothing for that person over that year, so they're going to be on medications through that period. If say the ablation doesn't give the response that you would have ideally liked, maybe medications are what we use to supplement an ablation that didn't work as well as you hoped. So maybe we flip it and say, instead of doing medications first, we do ablation and then give medicines after. I mean, I don't know that we know those answers yet.
Great talk. I was returning last night from New Zealand, and at the airport, the Customs and Border Protection agent, asked me, where did you go and what, so on and so forth. So I said, I'm returning from a cardiology conference, and he asked me, I've had AFib for the last 3-4 months, and it's happening more and more. What should I do? Should I do an ablation? I said, I think you should. It's very safe and it's very effective. So after hearing your talk, I'm glad I told him that. Secondly, it is quite enviable for me as an interventional cardiologist to see that you can derive the first 3 conclusions there on that last slide, which I don't think we can say in the world of coronary interventions. I also do structural heart interventions, and on a weekly basis, I see several patients with severe MR, severe TR, and invariably when I go back and look at their history, vast majority of them have had atrial fibrillation for many, many years, 10 plus years, and have not had any attempts or minimal attempts at restoration of sinus rhythm. So from all the data that you have in this field, are there any strong hard data to show that restoration of sinus rhythm, one way or the other, or by ablation, reduces the incidence of severe valvular dysfunction over a long period of time in these patients?
So I don't know that I can definitively answer that. Atrial fibrillation does result in tricuspid annular dilatation. Probably you also see the same thing with the mitral. So you'll see a worsening in valvular regurgitation in patients who have persistent atrial fibrillation. Can I say that doing an ablation once you have TR and MR is going to undo that to a substantial degree? It's hard to know. Like, someone's been in atrial fibrillation for 10 years, probably not. Like, I have little expectation that it's going to change much at that point. 10 years ago, could we have prevented some of this? I think that probably you would have. This is the difficulty now, is that, as, let's say, an EP community, our studies are designed around 12-month AF recurrence outcomes as a binary event, and that is a legacy of 20 years of trials. It does not tell the story, it does not capture the outcomes that we want to capture, and it neglects the fact that these patients will live with this condition for 20 years. And so, administrative data may help to some extent. I don't know that we're ever going to get a definitive answer around that, but conceptually, it makes sense. I mean, a month ago at ESC, we had a working group between an EP community, heart failure community and some interventional cardiologists who do mitral clips and tricuspid clips around, should we be thinking about these outcomes as 3 different communities instead of in isolation? And I think we should. I think it's definitively an area of study. The question is just how are we going to get those answers? And I think it'll be a while before we know.
So thanks for the great talk. I appreciate the idea of prevention and investing a lot in it in terms of preventing the progression. But when we talk about operationalizing something like this, taking 9 months in Canada to get to that ablation, it sounded like a lot of the indicators to trigger that intervention were based off of history. How often are they having these AFib recurrences, palpitations? Is there a role for some other type of subclinical marker investigation to identify this heterogeneous population, who's going to actually progress versus not, by EKG, imaging, biomarkers? How do you identify those, or is it just based off of history?
So probably there is. I mean, there's risk scores that have been employed to predict progression. So there's another study that was done, Karl-Heinz Cook's group published it about a year before we did our progression study. And they used a score called Hatch. And so it's just a marker of AF progression. It's also a marker of AF recurrence. The C statistics on these are not very good. I think that, from a community perspective, the idea of an intervention to prevent progression of atrial fibrillation is still very nascent. I don't think we have necessarily explored this anywhere near where we should. It's been a push over the past couple of years to try and conceptualize this as, like asthma. It's a chronic progressive disease with exacerbations. You treat the exacerbations, but as an EP community, we've never gotten people onto inhaled corticosteroids to settle the disease. We've seen some of that work in terms of just risk factor optimization out of the Adelaide group. And I think that that's now percolating in, like we're seeing in the US guidelines that just came out. It's not only a foundation, but it's also a pillar of management. So it's becoming a central aspect of the disease. But the idea that progression is an endpoint that we should be targeting isn't quite as accepted, let's say. And so I think what we'll see over the next couple of years is that studies are going to be focused on this and are going to be aiming to look at it. The problem is that within the studies that we have, the number of progressions are 15, 20 patients out of 300, right? They're still so small that it's hard to generate those risk scores and the biomarkers. I mean, in principle, we know that more advanced forms of atrial myopathy and all the things that go along with it, so like ANP, markers of fibrosis, MRI is not good at characterizing atrial fibrosis yet, but what seems to be there suggests that that's going to predict progression. And then just clinical things like the general cardiovascular risk factors.
Thank you. That was excellent presentation and discussion.